Let's get our panel up here, and while we're doing that, just a housekeeping announcement. The Mike English's talk on the humanitarian stuff that's gonna occur at dinner. So once we finish with the case presentation and discussions, then it's off for cocktails and dinner. Any other announcements, Sig? Everything?
No, yeah, so we'll transition from dinner when you give the word.
Uh-huh.
Having said that, I thought that was just a terrific series of talks. I really enjoyed that. I think the juxtaposition of thinking about the adult and the pediatric patient together is so useful, and so often we're in different venues, and bringing it together, it really complements each other well. My question is, and I'll address this to the whole panel, but maybe, Mike, you mentioned that it's so rare that you're operating on a primary thoracic curve in adults. So when somebody's got a 1A curve, how big can we let that go? An asymptomatic 1A curve in a 16-year-old who's post-menarche, when do we really need to operate on that? The point being that that's very rarely a symptomatic curve in the adult. So does 50 degree become a threshold, or when you let these go?
Sharon?
So I think that's a really difficult question because the indications for surgical intervention have been based on the Cobb measurement almost exclusively. It's not looking at future pain, future disability, or anything along those lines. And yet, the most common reason to go to the operating room for the pediatric surgeons is the 50-degree thoracic curve. So part of me wonders is, are we not seeing as many of those curves being large and symptomatic in the adult population because we're attacking them earlier? Or is that part of the confounding variable? And then when it comes to the adolescents, in my practice, the large thoracic curves are very symptomatic. The trouble is I don't know how well I can correlate the size of the curve to those symptoms, and whether those symptoms are a result of the most recent growth spurt they've gone through and the changes that the thoracic cage is going through, and will that settle down and go away as an adult?
I'll throw this one out. What about their compensatory lumbar curve? I mean, what do we operate on the adult side of the world? Like you said, it's usually not their symptomatic thoracic pain, it's their degenerative lumbar issues. And you can make the argument that if you take a thoracic curve with a compensatory lumbar curve and treat the thoracic curve, that perhaps their lumbar curve won't be an issue when they're an adult, but again, something that's unproven.
Well, that's why I said the A modifier, because I do think that the 1B1Cs, if it's truly a compensatory, so it's a B or C, those are ones I'm actually most aggressive about operating on, because there I think I can help natural history, but the A modifier, I can't make that any better. And so you're saying you're operating based on symptoms, and an asymptomatic patient becomes difficult. Maybe just one more scenario, then we'll go to cases or something. But the other one I find really difficult is the 3C, right? So somebody who, and you showed a number of these where you got to go down to L4, and somebody who's truly asymptomatic, are we really doing them a lot of benefit? If you got to go down to L4, so to me, operating on the 1B1C, those are simple, and those I really think I'm doing something good. But a 3C, where I can't do a selective fusion, what are your criteria there?
Well, the 3C is why I think a conference like this could be so beneficial, because it could help people like me and Matt communicate more with the adult guys. Because a lot of times you have to go to 3, and a lot of times you're going to end up going to 4. And you do leave the operating room wondering, have I done the patient any favors here? Because I usually let them get pretty darn big. Like I'll let the lumbar curve get into the 60s and 70s before I touch it. So my criteria usually is I wait to see what the lumbar curve is going to do in the 3Cs. If I think it's a curve near 50, where if I attack now, I can stop at L3, then I'll do it. If it's one where I think I'm going to have to go to L4, I'll let it get into the 60s and 70s.
Okay, what about the same question for a lanky 5?
For what?
A lanky 5. And that's to you too, Sig.
Yeah, so just as the thoracolumbar curve, and that to me just goes more with symptoms, right? I like an anterior approach for a type 5 curve, but that's kind of, I don't have a clear threshold there in terms of progression. But I guess what I'm getting at, I'd be interested, Mike, in your take on these, because you've been doing this for a long time. In Minnesota, everybody got a surgery. In Iowa, nobody got a surgery. The thought was everybody came from Iowa to Minnesota. But I'd be interested in your input on it, because these are really, really tough decisions.
Yeah, I think it's almost an ethics issue at some point, but I think one issue is, and you obviously you never want to take it for granted and be cavalier about it, but we can treat a right thoracic curve in an adolescent patient fairly effectively and very safely. So we don't treat many adults with thoracic-only curves, because by the time you get to be an older adult, you probably don't have the self-image issues that the adolescents and young adults are going to have. So if you can safely treat a young adolescent and improve their self-image and also reduce their chances of curve progression down the road, I think it's reasonable.
And I would just make one general comment, since I do adolescents and adults, is over the course of my career, I've gotten far more conservative in operating on the lanky threes or the double major curves, far more conservative. I'm a little bit more aggressive actually on the thoracic only curves, because they're already stiff because of their thoracic spine and the rib cage issue. And then I just get to, well, how far into the lumbar spine am I going to have to go? But I'm more aggressive on those and less aggressive on the threes.
Well, this will take us into a case. I'll show the first one, use the moderator's privilege here, and plus I need help from my pediatric colleagues. This is a patient that is 13 and a half years old. Her scoliosis was picked up about 6 months ago by a nurse practitioner in one of the indigent clinics, but they never saw anybody after that. Subsequently seen in the clinic again just about 3 months ago or so, and these x-rays were obtained by the primary care provider. But again, never did get to see me or anybody else until just recently. So here she was about 3 months or so ago with these x-rays were taken in the other clinic. Here she is when I saw her just the other day. So you can see over a relatively short period of time has had continued and significant curve progression, and along the lines with what we're talking about here, pretty significant deformity. Clinically, I just snapped these pictures with the iPhone in the office this past week when I saw her. Even though she has a significant structural lumbar curve, clinically looking at her, she really looks more thoracic. And here's some bending films. Obviously, her thoracic curve is very stiff. Lumbar curve is stiff, but not as stiff. And then she's got a fixed obliquity at the lumbosacral junction on her right side bending. So do you just hit the back button here? How do we back this up? We know?
There's a little button below, arrow pointing the other way.
Below and left.
There. So obviously, rapidly progressive curve. Let's have some comments from my colleagues here as far as how do we address this. First of all, does she need further imaging with, even though she's 13 and a half and has started menses, does the fact that her curve is so rapidly progressive make you want to do any advanced imaging or not?
Yeah, I think in general, just looking at it, what I was taught is if you're ever thinking, should I get it, you should get it. Mm-hmm. And so with this being the first time you've seen her, even though she's got imaging from however long that was before, I would probably get it just to make sure. It's a fairly routine curve, but just given the size of it and nobody's ever picked it up before, you haven't seen it before, I would do it just to be safe. There's been a few times I've picked up a Syrinx or a Chiari occasionally here and there that I'll find, so I probably would image her just to make sure, just to take that off the table.
Would everybody agree with that, or do you think
I
it's
would,
necessary?
for sure.
Yeah, I don't think there's a downside other than the cost. But
Other than cost. Okay.
Just to clarify, that would be a MRI of the total CNS?
Yeah, cervical thoracic lumbar, yeah.
My
Including-
neurosurgeons
including
ask
brain?
me. Yeah, they ask me. My neurosurgeons ask me to get the brain every time.
Yeah, yeah. Okay. So what do we do with her now?
Assuming the MRI looked okay.
Assuming her MRI looks okay, and I assume everybody agrees that she's surgical. Selective thoracic fusion?
I hate to be the one who say it, but I would say no on
Yeah.
the selective thoracic fusion. So there are a couple of reasons for me. The ratio of the Cobb angles is not in her favor. The size of the lumbar curve, and then that truncal shift to the right. So if you do a selective thoracic fusion and you lengthen the thorax and straighten it out, your compensatory curve is not going to restore her truncal balance very well. So I would have a long conversation with this family and say we're looking at a lengthy fusion, including both curves.
Especially given the fact that she's still Risser 1, I think it's Risser 1 there, 0 or 1, and she's still got growth that if you just do a selective thoracic, that lumbar curve just continue to progress.
The other,
do something about it.
yeah, the other issue is even though she's 13 and a half and has started her periods, she's tiny. She looks
Yeah.
like an 8-year-old.
Well, her physis and her femoral heads are still open, and so she's still got lots of growth to go.
So where do we go distally?
I think that's the struggle.
Yeah.
I mean, if you could not go to L4, that would be nice.
I
think you might be stuck going to L4 looking at that, but I'm looking at it.
Yeah, the only way I've been able to deal with this in the past is in a few cases I've gone anteriorly and do like L1 to L3 where you can get a little overcorrection and then go posteriorly. And sometimes I think you can save a level. That's a very aggressive approach to save a level, but I have done that.
And it looked like the bender maybe went off, but it doesn't look like her L3 pedicle gets across the center sacral line at all.
Yeah.
Even on her best bend.
I don't even think L4 gets over there very well.
It's close. But I think the lowest instrumented vertebra would have to be 4.
Yeah.
And I would not go anterior. I'd probably go L4 to T4. Looking at her left shoulder is a little bit low, so I try to push up that shoulder, stop at 4, so
Yeah.
4 to 4.
Yeah. And the other issue, pertinent to our host is that she requires smaller implants. She can't use existing adult stuff because she is so tiny.
So I heard someone comment on shoulder balance. Any rules of thumb you go by for your shoulder balance? And at least I will tell you from a medical literature standpoint, there's pretty much every study says that we don't do a very good job of predicting their postoperative shoulder balance. Do you find it an important thing for your patients? Do you have an algorithm you particularly use?
Sure, yeah. So if the concave side shoulder is low, I typically stop at T4. If they're about equal, I stop at T3. If it's high, I stop at T2. And I'd say on some of the times, especially earlier in my career, when I didn't balance the shoulders well, those were some of my absolute unhappiest patients.
Yeah, because that's one thing that they can see.
I think
And
it's
their
very
bra,
important.
Their bra, slips off that side, and they get upset by that. Part of the reason why they do it. But I also find that there's not a whole lot of work that needs to be done to get them balanced in their shoulders. Because once you got them prone on the table, I feel like their shoulders often, especially she's going to be relatively flexible given how small she is. I get a fluoro shot looking at her clavicle intra-op just to make sure that she's positioned in a way where if I fuse her in that spot, she's going to
Yeah.
be close to being balanced.
I usually use hooks at the upper instrumented vertebrae, so I use a downgoing TP hook and I pull it down on the right side a little bit harder than I do on the left. And it usually corrects it pretty well.
What do you think? Do you think curve progression is linear? Maybe again going back to the Iowa data or
No way.
Minnesota. So does the curve progress from 50 to 70 or does it go from 70 to 80 as fast as it goes from 60 to 70, for example? And to some extent, I can't tell you how many patients I've got like this who want to be a collegiate, and especially at age 13, 14, they don't yet know that they're not, the parents don't yet know they're not going to be a collegiate volleyball player, they're not going to be a collegiate track and field athlete. But they're very good athletes for their age, for example, completely asymptomatic. And a number of people who actually are, 16-year-olds, 17-year-olds, who are Division I recruits for volleyball for maybe 16-year-olds different than this scenario, I have to admit. So 16-year-old totally asymptomatic who's going to play college sports doesn't get fusion in my hands. And it's interesting how few of them come back after college for a fusion. But I'm not sure, in terms of the pattern of progression, I'm not completely sure that going from 68 to 78 is naturally what's going to happen here. And I think I'm suggesting to you that I really don't like the idea of going to L4 and somebody who's completely normal, athletic. I really don't like that. And as somebody who sees that transition, this is somebody who's probably going to be in their 40s before this really affects their health or quality of life. And golly, when somebody 30 years from now or 20 years from now, I think we'll be doing this a lot differently.
I think it's a great point, Sig. I see a fair amount of athletes as well, and I'll tell them, look, try to get through your athletic career. I have remember a patient vividly who very similar curve pattern. He was a catcher. He was finishing up high school, but he was going to get likely drafted into the minor leagues. And I said, look, come back. We can still monitor this. Just because we're not going to do surgery doesn't mean you don't come in. And if it looks like this is just progressing rapidly, then you can always bite the bullet and take care of it. But I think there's very little harm done in just taking a watchful observational approach. And I agree with you. It's very seldom, and I don't know why that is when they finish their athletic career. I don't know if it's because life takes over and they get a career and then they have kids and you don't see them again until their life resurfaces 55, but they do rarely come back.
If you look at her clinically, as you were mentioning, she looks pretty well balanced. Without the adding forward bending, you'd say that that's a pretty high-level curve. Maybe if she has a bathing suit on, it might not be. But if she's wearing clothes,
Well,
I don't think people would think you have a 78-degree curve.
and it could be evidenced by the fact that nobody even knew it, I guess. But again, her just 3 months ago, that's where she was.
Well, and to Sig's point, this is something again that I think we as a group could really help each other out. I would love to know, is she going to have as good an outcome if we leave her until she's 40 and she's symptomatic? How much more morbid is that surgery? How well has she done from 15 till 40? We don't know what the answers to those questions are. So I would love to have some way to gather data on that.
And getting her back in 3 or 4 months and getting some more films, I don't think she's going to progress that much. Surgical decision any different. I don't think you're going to have to extend to L5 at that point.
No.
So, especially seeing someone for the first time and having this unbelievable discussion with her and her family, I think time
Well,
would be a really good thing to, number one, see if this is a progressive deformity, let the families figure out the gravity of what they're telling
yeah.
the patient and their family about the surgery that she's needing.
Well, and we all deal with these. This is obviously a patient that they don't have a lot of resources, and so it's probably okay to go slow. But 3 more months and she's progressed another 10 or 15 degrees. It would be a little worried that I can't even go to L4 and do anything.
Yeah, it'll be stiff.
Yeah. Well,
So what did you do?
One quick question. Would anybody do anything about the rib prominence? Would they just try to derotate that out? Would they do a thoracoplasty over 3 or 4 levels in someone who's, has no pain? What about, how do you deal with that?
I've kind of given up on thoracoplasties myself, but what, Jaron, do you?
I just do the best correction I can. I talk to the family and say, the approximate percentage of correction I'm going to get on the Cobb angle will probably correlate relatively well with the derotation, and we're just going to accept that and be okay with it. And because the patient can't see it, they tend not to worry that much about it, in my experience.
Yeah, same.
Shall we go have drinks and dinner, or?
Well, show us what you did, man.
Oh, I just saw her.
Yeah. This is.
I don't.
He's
that's why
gaining
she's here.
advice.
Yeah.
Touche. What are you gonna do? Yeah, you heard everybody.
Send her to Denver.
It's gonna wait.